Good evening and welcome. We're thrilled that you're here to hear this very important discussion. I'm Dan Kaplan, and I've had the distinct honor and privilege of serving as president and chairman of the board of the 92nd Street Y. I was very thrilled that Susan Engel, who you normally see at this time, and Henry Timms asked me to plan tonight's panel discussion. As you know, the Y's lecture programs are among the most comprehensive in the United States, covering a great range of subjects and with great speakers. As an example, on November 1st, Malcolm Gladwell, whose books include The Outliers and others, will be here, and on November 8th, Archbishop Timothy Dolan, Archbishop of New York, will join Rabbi Newman Levy to discuss finding faith in these very difficult times. Please visit the Y website to order tickets so that you can participate. And now for tonight's program. The format is a moderated panel discussion, and I particularly hope that it will be moderate. This is a passionate subject to many people. Part of the passion is based on lack of information and the misinformation that has been propagated about healthcare. At the end of the panel's discussion, you are free to ask questions. Please don't run for elected office tonight. We encourage you to go to the microphones that will be on the aisles, and before you ask your questions, please identify, if possible, if you are affiliated with a medical institution, if any, because we are honored in this audience to have many leading medical professions and medical students, and we really look forward to an enlightened and intelligent discussion with our esteemed audience. Incidentally, will the medical students who are here tonight please stand for a second so we can greet you. Welcome. We are thrilled to have you here, and it is your future and ours that will be discussed tonight. Tonight's very timely and particularly important discussion would not have been possible were it not for the passion and commitment to quality health for all people of Paul O'Neill. I met Paul in the 80s when I served as a senior executive of a forest products company, and he was president of International Paper. He was a brilliant, passionate, and innovative executive. After International Paper, Paul served as CEO and chairman of Alcoa during the years of its greatest growth and prosperity. After retiring in 2000, he, despite my misgivings, accepted President Bush's offer, and on January 21st, Paul O'Neill became the 72nd United States Secretary of Treasury. After Treasury, Paul has served on numerous boards of directors, both profit and nonprofit. In his one prior appearance at the 92nd Street Y, Paul discussed the decision-making styles of 3 U.S. presidents that he served in senior capacities. Paul brings very special qualifications to tonight's panel, all of whom he recruited to join him. In 1977, he co-founded the Pittsburgh Regional Healthcare Initiative to address the healthcare problems in a large region of Pennsylvania. Over the years, he has been a leader in analyzing, discussing, and trying to solve diverse issues of patient safety and quality care. On a personal note, and additionally, with 4 children, 12 grandchildren, and 7 great children, he better help improve the healthcare system. It is a very special pleasure for me to introduce to you a good friend, a dear friend, and a great American, Paul O'Neill.
Thank you, Dan. It's a pleasure to be with you tonight, and I'm anxious to get on with our program, and I want to introduce to you the other members of our panel. And I'd appreciate, why don't you all come out, and I will introduce you as you're coming out. First, we're pleased beyond words to have Lesley Stahl here to moderate our panel. This is a really special person, and I'm personally sorry. I hope my wife taped it for me, the 60-minute segment that she's doing right now. Next to Lesley is Dr. Donald Berwick. He's a pediatrician, but these days he is the leader of the Centers for Medicare and Medicaid in Washington, which is the biggest healthcare payer in the world. He's a great friend and a wonderful human being, and as the conversation develops, you will hear about his own passion, dedication, 20 years worth of leadership of an organization called the Institute for Healthcare Improvement, where he and I have had worked together over this last 20 years. And the crux of what we want to talk about tonight is our shared belief that it's possible to simultaneously do two things. One, to greatly improve outcomes from medical care interventions and reduce the cost of medical care $1 trillion a year out of the $2.5 trillion we're spending. Down $1 trillion. Next to Don is Dr. Robert Grossman, who is the Dean and the CEO of the New York University Langone Medical Center and School. He also is a fabulous doctor. You're lucky to have him here in New York City overseeing such a major medical enterprise. And next to Dr. Grossman is my friend Ken Langone. He is a co-founder with Bernie Marcus of Home Depot. But if you drive down the avenue, you can see his name on the building that he cares about at the Langone NYU Medical Center, where he gives time and attention and huge financial support for their efforts to be the best in the world at what they do. And so I'm pleased to welcome all the panelists. And to set this up for you a little bit, this is an area I've been interested in for a long time, beginning when I first went to the government in 1961. But over time, my interest in health medical care has been blended with my interest in questions of leadership and what it means to be a leader. And one of those things that I believe demonstrates leadership is an institution where the people never get hurt at work. So when I was at Alcoa, I said in my first meeting with a New York security analyst, if you want to measure how we're doing, I'm going to report to you every quarter when I come here, before I tell you about financial things, I'm going to tell you about the injury rate to the 140,000 people who work around the world for Alcoa, and if it's not getting better, then you can tell I'm not really a leader. I have to tell you, the financial analysts were mystified to have a CEO of a major company come and talk to them about the safety of the workforce. Over time, we became the safest significant size company in the world, so that the injury rates were counted behind the decimal point, actually between 0.1 and 0.05. And so I want to set this up for you by telling you today the injury rate among people who deliver care in the United States is between 30 and 50 times higher than it is in places like Alcoa and DuPont and other challenging environments. And I think that if we could get people in the medical community to resolve that they're going to create a workplace where their people are never hurt. They would have to learn the techniques and practices of continuous learning, continuous improvement, and we would be well on our way to better outcomes and $1 trillion a year worth of saving. So with that beginning, I want to turn it over to Lesley and join my friends on the stage.
Thank you. Thank you. So my first question is for the audience. Why aren't you home watching 60 Minutes? I know why you're not home. It's the same reason I'm not home, because I really wanted to hear what these gentlemen have to say. What I'm going to do, let's do a round. All right? We'll go around. We'll start with Dr. Berwick. Give us your best idea for reducing health costs. It can be a small idea or a huge idea, but it has to come up with a substantial saving. And Dr. Berwick, since you're running the Medicare program, let me ask you to be specific and give us an idea of saving money in the Medicare program.
Well, thank you very much. And let me just express my personal thanks to Paul for getting me involved here. I do anything Paul asked me to do. He's a great mentor and friend, and Paul, we're all in your debt for your leadership. I don't want to answer your question without mentioning another important objective, and that's justice. That we are not a country until recently that has decided to make healthcare a human right.
A human right?
Everyone has access. In our system, we are now en route to that, and any discussion about sustainability or cost, I think, should be couched in terms of a majestic agenda, which is to make sure that if you're in America, you have health care. We're en route to that. The problem, of course, is then we just can't, in my opinion, we cannot and should not let up on that. Now the question is how to make that sustainable. Costs are way out of control. We're spending double the amount per capita on health care of the next most expensive nation. Our health care is not that much better, and it just isn't going to work. It wouldn't have worked anyway if we didn't cover 32 million more people with the new Affordable Care Act. So there has to be another agenda, and there's a choice there. You can make health care affordable by cutting it, by withholding it, withdrawing it, limiting it, taking things away from people. And there are those who would like to do that. The answer to your question is that that's the wrong way to do it, and the right way to do it is to improve care. And that's something we've had a lot of trouble engaging the public and understanding deeply just how much improvement is accessible with courage and commitment as the solution to the cost problem. I've been thinking lately about 6 areas of waste, and I'll give you examples of what they look like. They are enormously expensive. I don't know if it's the $1 trillion that Paul mentioned, but it's of that order of magnitude. There's the waste of failing to coordinate care. We built healthcare in fragments. Ask anyone with chronic illness, as they are passed from specialist to primary care to hospital to home to nursing home to rehab back to, they get dropped, they get lost, they get confused, and they get complications. And there are 20% of Medicare patients who are discharged from the hospital with congestive heart failure are back in the hospital 30 days later. And almost all of those readmissions can be prevented with appropriate coordination, but we never built it that way. We have to. A second is I call failures of execution, the most charismatic of which is safety issues. People get infections, they get pressure ulcers, they get post-operative complications, they get the wrong medication. The secret news is that we know how to prevent it. There are places in this country that have reduced pressure ulcers by 95%, that have eliminated infections for 5 years running. We just don't have a way to deploy that kind of change everywhere it could help. Tremendously expensive problem. So solving that problem improves care and reduces cost. A third area is overuse of unnecessary care. People get all sorts of care that cannot possibly help them. The reasons are tentacular and difficult to explore, but we can get into that if the audience wants. But that's a big bill. A fourth is administrative complexities. We pay a easily double-digit percentage of the transaction costs in American healthcare are simply administrative procedures that are wasteful. They help no one at all. Ask a nurse how she spends her day. She'll report that 40% of her time, 50% of her time is spent in non-value-added activities. A fifth is pricing failures. Paul's been a particularly accurate critic there. The way we price healthcare, it wouldn't be acceptable in any other in any other responsible system. And the last is fraud and abuse, not something I was too schooled on before I took the job I have now, but it's massive. It's tens and tens of billions of dollars in a very tiny sector of healthcare delivery, but people are stealing, and that has to be stopped. That list alone, and that's an incomplete list, would more than pay the bill, double pay the bill of the extra people we're going to cover with the Affordable Care Act.
Well, before we're finished, we're going to get into many of those to see how you can get from saying we have to do it to doing it. But I want to ask Paul, if you would tell the audience a story you told me on the phone. This is about one way to save some money, but tell that whole story, the one
All
about
right,
the Pittsburgh.
so I want to start with a big idea, and then I'm going to tell the story Lesley wants me to tell.
Okay.
Now, here's a big idea, which I've had an opportunity to say to people around the president and to write in newspapers and things like that. Here's the idea. At 8 o'clock in the morning, every healthcare institution in the country, acute care hospitals, nursing homes, all the rest, should hook up to the internet and post on the internet all newly acquired hospital infections in the previous 24 hours, every patient fall, and every medication error. Now, if we did that, there would be 4,500 new hospital-acquired infections posted every day. There would be one patient fall for every acute care bed every year, and there would be 800,000 newly identified medication errors posted every day. So when I said this to my friend Lucian Leap, who's a famous doc who works in this area in Boston, he said, "Oh my God, Paul, the system would be overwhelmed with 800,000 medication errors." And I said to him, "Lucian, you don't understand. You're thinking command and control, and somebody on top of the pyramid has to act on it. I'm thinking Facebook." So now I want to tell you a story that Lesley is prompting me to tell you. Dan said in 1997, I co-founded something called the Pittsburgh Regional Healthcare Initiative. And as our first effort, we said we need to do measurable things. One of those things that plagues health medical care is something called central line infection. So we have lots of docs here, subclavian line that goes in for nutrition or medication, or a femoral line that goes in the groin for the same purposes. And the infection rates are unbelievable. And so we said to ourselves, we are going to set an objective to eliminate these infections in southwestern Pennsylvania. And in one particular hospital where we had really good traction with a doc who was working there, this is Allegheny General Hospital. I give you some numbers to frame this for you. In the base period, there were 1,758 patients in a year's time who went through these intensive care units, and 39 of them got an infection, and 19 of them died. And after these practices of continuous learning, continuous improvement were put in place to basically identify and common practices, so that all the nurses had gone to school in different places. They all thought you did site preparation in a different way. Some thought you did it with a swab. Some thought you did it with a cotton ball. They had different ideas about what the right antiseptic was. And so after we realized that we had this huge variation in what they were doing, they agreed to adopt one practice and see if they could begin to make a difference. And in a year's time, we got to a point in the subsequent year where they had 1,850 patients. They had one infection, and no one died.
Wow.
Now, you know, we've repeated this experience at the University of Pennsylvania, where Dr. Grossman has some experience, in an oncology ward, where Dr. Richard Shannon has eliminated infections for people whose immune system is compromised by chemotherapy and radiology. And if you go across the country, you can find isolated pockets where it's true that these ideas are being practiced. The dilemma is, why is it that since 1999, when the Institute of Medicine first wrote its report called To Err as a Human and said we're killing they said 99,000. I think it's a huge underestimate because of things gone wrong in medical care. From reports that have recently been made by Don's organization and affiliated organizations, since 1999, we've made no progress nationally on things we've demonstrated is possible to change.
Okay, so I want, before you tell us your idea, Dr. Grossman, for how your best thought on how to reduce costs, just respond to what Paul O'Neill just said, that there are hospitals that are finding ways to make patient care more safe and less expensive, but other hospitals don't follow what they've already learned. Why is that? What can you do about it?
Well, first of all, I agree totally with what Don and Paul have said, that in fact, quality is absolutely cost effective. And for us at NYU Langone, what we've done goes along with what Paul said. We have a lot of transparency with respect to outcomes and data. And that data is known across the institution, and it creates a climate of accountability for the physicians as well as for the institution. And it also drives the highly competitive nature of the individuals within the institution, and not only within the institution, outside of the institution. And indeed, there are sites that actually objectively look at quality, and you have to be able to find them because they're not necessarily U.S. News and World Report. But if you look at the Commonwealth Fund site, Why Not the Best, they take the CMS data and objectively look at it, and you can compare institutions with respect to their quality. And I think that is very cost effective and very important if you want to do exactly what you were saying.
Did you have a thought, a proposal to make for how to get the cost down?
Well, just a slightly different approach, and I think this is happening, but clearly hospitals are very expensive. And what you're seeing is a general trend from inpatient to ambulatory. And if you can accelerate that trend and align the incentives so the ambulatory system receives the appropriate compensation, then I think you can make a big dent in some of the expenses in our healthcare system. And it would be quality, and it would definitely improve quality, because also, as Paul was saying, hospitals are extremely, there are issues with respect to the dangers of infections, falls, all the things that, medication errors, all the things that occur in hospitals. And you want to get the patients out, you want to treat the patient, get them out of the hospital, but actually you would most likely, if you had your druthers, like to perform most of the procedures and care on an ambulatory basis.
Does Medicare pay for that?
Yeah.
The ambulatory?
Yeah, absolutely.
Okay, all right.
Yeah.
What is your proposal, Ken?
But there, I just would say there is significant misalignment in the Medicaid system between inpatient and ambulatory, and that is a problem, and that is a significant cost, where the ambulatory care is tremendously undervalued and the hospital care is costly.
Ken, I'd love to hear your idea, but also someone who's run such a big company, talk about the problem of having ideas. There are all kinds of ideas. How do we ever get them implemented? Because you have to kind of bomb the system that is and start all over again if we're really going to get every proposal we've heard implemented.
I don't think that's so. I happen to be right now what is very unpopular to be in America, which is a capitalist. And,
just a smattering of applause out there.
we are on the cusp of a choice in America, and this is not political. We either have to decide that we want government to do more for us or less for us, and that's a choice. But it ought to be a choice that's so profoundly clear that our leaders understand this is where we want to go. Let me tie it back to medicine. With all due respect to these different challenges and opportunities, None of these things would be necessary if people didn't get into the healthcare system to begin with. Infection rates. Home Depot was a very simple idea. Low prices, wide assortment, high service levels. And people told us when we went out to raise the $2 million we raised to start the company, they told us you couldn't do it. You couldn't have high service levels, low prices, and a wide assortment. But they were thinking in the context of a $4 million building, $4 million store. Our idea was that if we did it right, we would do 18 to 20 million. The average Home Depot store today does $37 million a year. So your fixed costs are covered. But let me go back to capitalism and healthcare. And we've already done it in this country. We did it with smoking. There are a lot of diseases you can't prevent. Cancer, Alzheimer's, a lot of things that just happen. It's genetic, whatever it is. But 40% of the American people are overweight. And the biggest single challenge to me, to the healthcare system, epidemic, is diabetes. And from diabetes comes infections, because you do amputations, you have circulatory problems, on and on and on. Just like we forced, and I think it's a fair word, just like we forced the American people to effectively stop smoking, we have to go the other way. We have to give people incentives. And if you think the government is going to be able to pay all your health care needs, then you have to take your Social Security check or your pension check or your paycheck and sign it over to the government and give them that money, and then they provide you the service, if that's what you want. I don't think that's what we want in America. But I do believe we are essentially entrepreneurs. And what we have to do, the big idea to me, is how do we motivate people to do things for themselves that makes them healthier as human beings, that results in less need for the kind of care that leads to infection or leads to days' length in the hospital. I mean, think of the horrors of circulatory problems that come from diabetes. And it is, make no bones about it, put heart trouble, put mental illness, put everything else up against it. They pale in comparison to the enormity of the problem of our basic health that we can do something about. We can absolutely do something about it. What we have to do is figure a way out to give people an incentive. The biggest incentive should be they're going to feel better, but you need more than that. So let's figure a way out that those of us who comply with certain measures pay lower premiums. Ironically, we should pay lower premiums because the likelihood of us demanding more out of the system will go down by virtue of our better health, whether it's walking every day, whether it's eating more fruits and vegetables, there's a million different things we can do. But we can't expect ourselves to abuse ourselves and have somebody else pay for it. The system won't work.
Can I ask you all to talk about an idea that I keep reading about? First, tell me if you think that it's possible that we could change the system dramatically. I'm talking about fee-for-service, and whether there is an inevitability that we are moving to change fee-for-service to something more what they call global, or whatever that means, and explain what the alternative would be, and more importantly, how we would get there, and if this is one of the answers. Who wants to start? You want to start, Dr. Berwick?
Sure. It's a very pluralistic country. The more I travel around, and I travel a lot, I see there are so many different contexts, and I am not willing to give up on any particular context. There are places in this country which are currently so embedded in fee-for-service, they really can't change. And places like that, changing the incentive structures and supports to learning how to reduce complications and improve patient care, and by improving care, reduce costs, is plausible. We have launched a $1 billion effort in this country called Partnership for Patients, run by a component of my organization that's reaching out to all the hospitals in America to try to do exactly what Paul guided Langone to do. And we're seeing some results. You know, there's a 53% decline in central line infections in this country documented by CDC over the past 9 years, thanks largely to your efforts. That'll work to some extent in the fee-for-service sector. At the other extreme, we have managed care, Medicare Advantage. That's when you are in Medicare, you can join a health plan, and it takes care of you in its network for as long as you want to stay with it. And we have plenty we can do to help strengthen that program, put it under much tighter quality surveillance, and keep costs down. And part of the Affordable Care Act is doing that. There's a middle ground of migration toward coordinating care, which is that's the 800-pound gorilla here, finding ways to help you make a journey through care instead of experiencing fragments. Just last week, we launched one of the most important new rules out of the Affordable Care Act, the Accountable Care Organization. Very interesting idea. In a fee-for-service payment system, we can nonetheless attribute a panel of primary care patients to a doctor or a doctor in hospital that want to take care of that panel and help them coordinate. We can pay them for coordinating the care instead of for fragments.
Somebody explain how it would work. You go in to your doctor, and he diagnoses you with, I don't know, take something, gallbladder disease, something.
Congestive heart failure.
And then there's, what, a price tag put on what it would cost to treat that patient, and that's all that a group of doctors get? Dr. Grossman, how would that work?
Well, actually, you should ask the person who
Oh, all right.
actually,
Well,
but I'll say
your explanation.
I have major, and our institution have some reservation. The concept is a good and legitimate concept. The problem we have is the details of it, and I think that there is some data to show that it's very costly. In the New England Journal, there was a report about, I believe, 10 group practices that were designated ACOs, and at the end of 3 years, it was hard for some of them, and these are probably the best practices because they were chosen for a demonstration practice. It was hard for them actually to make money in the ACO model. Having said, and there's
What does ACO stand for?
Accountable Care Organization.
Okay.
The second aspect of it is the investment that one has to make, and it's a significant investment. It's an important investment, but the investment was about $1.7 million, according to this article, for the ACO. So they were starting a little bit behind the 8 ball. And how you manage certain aspects of it, particularly for places like New York, are challenging. Now, I haven't read the latest missive, but if you're responsible if you're in an accountable care organization, the accountable care organization is responsible for the care of a particular individual, and this individual spends a lot of time in Palm Beach. If he gets his care down in Palm Beach, the question is that the Accountable Care Organization is responsible, I believe, for that care. Now, okay, well, anyway, it's. I think these demonstration projects are interesting and important and potentially can improve care and provide value, but they're very difficult. And frankly, for us at NYU Langone, we have a number of trepidations.
Yeah, it's hard to see how you move. Anyway,
of course, we have trepidation. We're trying to change the American healthcare system from a legacy which rewards volume, and like Dr. Grossman's success, I suspect, from the viewpoint of his board, is measured by how full his beds are in part. The more patients are in beds, the more revenue.
No.
Well, for most hospitals, revenue.
it shouldn't be that way.
For most hospitals, success is occupancy. It's keeping beds full, more or less. We have a system organized around volume. What I'd love to be able to see is a hospital system that is figuring out every day how to help people stay home. The Accountable Care Organization, I'd love to talk with Dr. Grossman more about the details. I think we've got a fine rule now, offers an opportunity for those who wish to take it to work very hard on that and to benefit financially and have the patients benefit in terms of their clinical outcomes at the same time.
If you got away from, this is a question for anybody on the panel, if you got away from fee-for-service, how many fewer MRIs would we have? Would it be cut 20%, 40%?
Allow me to add something. The health care bill that was just passed should involve every single driver of cost, right? Where were the trial lawyers in that whole equation? Wait a minute.
Great question.
You want to talk
That
about
is a great
procedures.
question.
I wish I could figure out how many procedures are done at hospitals, pardon my French, because the doctors feel they have to cover their butt in case of a complication. See, the problem we have here is there are a vested interest. And by the way, this is not a Republican or Democrat. Lindsey Graham is in the pocket of the trial lawyers as much as any Democrat, and he's a Republican. This is insidious money, the amount of money that's poured into the political system to protect these interests. So when you talk about these procedures, sure, some of them are done not irresponsibly, but maybe excessively. But go
Defensive
back.
medicine.
I know if I was a doctor practicing medicine, I would say to myself, I'm going to make sure I do everything I can that, God forbid, this is the 1 in the 1 million patients.
I know.
I'm not going to be sued. I'm going to say, why didn't you do this? Well, I did that. Why didn't you do this? I did that.
Can I just?
Yeah.
Okay. So
go
because
and then
you probably don't know this, but I started my career in neurosurgery and became a neuroradiologist. So when you talk about MRI, it's close to my heart, and I would fundamentally like to make a couple comments about this. So first of all, when I started my career, there was no MRI and there was no CT, and we did something called exploratory surgeries, exploratory brain surgery, exploratory laparotomies, and they were dangerous, you killed people, and many times you didn't get the answer. And MRI and CT, ultrasound, et cetera, have totally changed the face of medicine for patients. They're safer, they're much more specific. They've actually, in my opinion, enabled cost-effective medicine. You can do a needle biopsy of a lesion in the abdomen and get the results next day. Before, patients were in the hospital a week, 2 weeks. Sometimes they really didn't survive the diagnostic procedure. And if you look at what I was saying earlier in terms of moving from inpatient to ambulatory and from long length of stay to shorter length of stay, in my opinion, much of that is a result of imaging. So to say that imaging isn't cost-effective, I think is a problematic statement.
But you can't deny that more MRIs are ordered than it
So I
would
think
be
what you
needed.
have to control are the conflicts of interest and self-referral. But it's very difficult, it is very difficult on an a priori basis to decide whether a patient who comes in after hitting their head should get a CT or not, in spite of a normal neurologic exam. And superimposed on that decision is exactly what Ken Langone said.
Yeah, defensive medicine.
You know,
Oh.
there's one more thing I worry about in this discussion. I think I'm right, Bob, that a full-time neurosurgeon doesn't really get going until he's about 35 years old.
Correct.
Okay? 35 years old. They've spent 18 years, more than half their life in school. I'm not talking about grammar school and high school. I'm talking about college, medical school, residencies, advanced residencies. You ought to come to one of our graduations, see the number of kids that come up and get their MD degree. That's the best day of the year for me. And you want to see the number of people that come up holding babies in their arms. Now, the biggest sin we'll create in this country, and by the way, let's look at the right side of it. We're living longer and we're living better than we ever have before. We're getting our money's worth. Now, we can do better, I don't disagree, but look at the length of life in America today. I'm 76 and I keep saying, gee, that's young now, right?
You're young.
but 50 years ago, 45 or 46 was where you were.
Right.
We better make sure that we make it financially attractive for the very best minds and the most dedicated people to come into medicine. Okay, and I feel very strongly about that. So whether it's fee for service or whether they work for us or however they're paid, you have to understand the enormous sacrifice. I like to walk through our place in the middle of the night. You want to see these kids sitting with their back to the wall, with their butt on the floor, with their books open, because they're studying among all the other things they have to do. This requires a passion and a dedication like I've certainly never seen. And let's make sure that all of this management we're doing and all of these cost controls we're doing and cost containment, we don't throw the baby out with the bathwater. That's all.
Paul. Come on, Paul.
You know, so I don't want to make a case for bean counters, but,
Remember,
you know,
I like you.
I
Right?
hunger for the day when the genius that Ken Langone brought to Home Depot in perfecting supply chain management, which means no inventories. If it's not moving, it shouldn't be here, is applied to health and medical care. So I'll give you a few facts. If you go to almost any hospital in the United States, you will find that they've got distributed medication cabinets around the wards, and something in the order of 10% of all the meds in hospitals are thrown away because they reach the expiration date. Believe me, Home Depot would not have been successful if they had to throw away 10% of their inventory. We can't even get the practice of ideas that we perfected in the Second World War applied to the practice of health and medical care. Believe me, I have a grandson who's in medical school at Tulane. The last thing I want to do is damage to his enthusiasm and commitment to being a medical care provider when he grows up in another 10 or 15 years. And so,
Don't stop paying the tuition.
so my angle on this is not to hurt the things we should cherish about health and medical care, but to rise to a standard. So, for example, 20% of an average nurse's time in the United States is spent hunting and fetching. You know, I've been involved in a lot of industries. I don't know of another industry where highly talented, brilliant people spend 20% of their time looking for IV pumps and other pieces of equipment, which, if they're organized correctly, eliminate that waste of time and provide more time for the nurses to be at the bedside. These are things that are double positives. These are things we can do. I want to come back for a minute to what Ken said about malpractice lawyers and all the rest of that. I believe for a long time that if you go across this country, you'd be hard-pressed to find a malevolent healthcare provider. That doesn't mean there aren't incidents and accidents and things gone wrong. There are. But I believe we should eliminate from our dictionary the term malpractice, and we should basically get the lawyers out of the medical care business. And we should say when an individual is injured, and there will be some, we should set up an arbitration board, and they should figure out what the economic loss to that injured individual is. And we ought to use general progressive tax money from the federal government to compensate people who are inadvertently harmed. And then we could get rid of the excuses about practicing defensive medicine, because you wouldn't have to do it anymore, because you're not going to be subject to a negative finding because you didn't order the 40th test. Two other facts. In Pennsylvania, in southwestern Pennsylvania, we have more MRI machines than they have in all of Canada. somehow that doesn't seem
Rest my
quite
case.
appropriate. Now, one other thing I would do, I would like to begin this conversation Lesley entered about fee-for-service by doing this. Again, I'm a great believer sunshine's a great sterilizer, and so I think it would be great if we could cause all of the institutions and health medical care and health insurance companies to post on the internet every contract they have, because people would be astounded to see the huge variation. It is truly as much as 3 or 4 times different for the same lives and the same condition, depending on whether you're in network or out of network. All these terms we made up, right? Doesn't have anything to do with your better health. It has to do with extracting resources from we the people. If we had this stuff on the internet, you could shop for medical care the way you shop for groceries by figuring out whether the quality is good enough and whether the price is competitive. That would be a beginning.
Hear, hear. Now, I want to ask Dr. Berwick to speak his mind, and then it's your turn to ask some questions.
Everybody's right. This is a really complicated, this is $2.6 or $2.7 trillion, 15% of the American economy. We've got 5,000 hospitals, 800,000 doctors, 3 million nurses. We are talking about a massive system that is not working properly. No single answer will work here. We need an American agenda for the reformation of healthcare using every one of the ideas you just heard. The good news, the optimism, I feel so optimistic about what's possible because I can see the success piece by piece. I see Rick Shannon knocking the socks off a condition that I was taught in my ICU rotation as a young resident was inevitable. Central line infections were inevitable. He brought them to 0. We talk about the supply chain management at Home Depot. We have Theta Care and Virginia Mason and Denver Health. Denver Health is using the Toyota production system applied in the healthcare world, $100 million of savings over the past 4 or 5 years, not harming a hair on a single individual's head and making more pride and joy in work because people are not producing waste. You like prevention? The diabetes prevention program now, it's going to spread to 2,000 YMCAs. In the initial prototype area, 58% reduction in admissions of diabetic patients through a patient education and involvement program. By the way, with no shift in money, nobody's penalized, they're just learning how to do it. Malpractice, we have Rick Boothman at University of Michigan, now copied by Tim McDonald, the University of Illinois, using a policy of extreme honesty, total disclosure of errors to patients, apology, instant, offers of compensation, and remedy. That is, what the patients want to know is it's not going to happen to somebody else. With that regime, 50% reduction in costs of malpractice in the entire system and doubling the number of patients who are compensated. For every problem we've got a solution in this country. What we need now is the will to understand the current system isn't going to work. We're going to have to agree together to change it.
What intrigues me is that there are ideas.
Yes, they're all over.
They're all over. Paul was telling me on the phone about the infections, and yet they're not duplicated, and someone learns something, and then it isn't instituted everywhere, where it should be. All these ideas should be everywhere.
We have to change the business model on one hand.
Eventually it will be implemented because the ones that don't embrace it will go out of business. That's happening. Cost effectiveness is as important in the healthcare field as in any business I've been involved in.
I wish I thought that was true.
Well, look at the number of hospitals that are shutting down. They can't compete.
I think
Bob?
that's true, Ken, but I bet you there isn't a single person here who really knows what they paid or their agent paid for any care they've had in the last 40 years.
We don't.
You don't know.
I want to ask you about, is there going to be a merger of your hospital with Continuum?
We'll stand strictly by what was in the New York Times on Friday. That's where it is. But Bob, I'd like...
It said that you're looking into it.
We're exploring the possibility of a strategic relationship.
But
That's where we are.
I'm asking you only because I read that article.
Right.
And the article said, now, you're going to tell me don't believe everything you see in the paper, but the article said it could lead to higher health costs because it would reduce competition.
That is utterly absurd. Okay, pardon me, that's dumb. That sounds like some reporter for the New York Times wrote that. Is that right?
Well, you read it.
Bob, I'd like Bob to just mention what we've done with Epic and what we've done with cost within our complex.
Sure.
And I must tell you, if you're going to have anything in life, have a great partner. And what this man has done at 4 years at this place in terms of making the outcomes better, the cost lower, the patient satisfaction higher. So go ahead. Don't let me down now, okay?
Well, there's a little hyperbole there, but it's so what we have done is stressed a culture of accountability throughout the healthcare system and throughout NYU Langone. And I think that alone, where you have objective data and you think about why the results are the results, lead to better results. And it's about infections, it's about readmissions, it's about mortality, all of those things. So they are, there's a lot of transparency throughout our medical center. In addition, what Ken was referring to was our deployment and rollout of our electronic health record. Now, I have to say that the electronic health record is a fabulous and incredibly important idea, but it costs a fortune. So for us at NYU Langone, we are spending $250 million for Epic. And I would say, unfortunately, at the same time that the government mandated an electronic health record, they should have mandated the jobs that went along with it to train people in the electronic health record to enable us to deploy it. Because what you have right now is competition between academic medical centers, hospitals for the small cohort of people who know anything about electronic health records, and you're competing with the private sector, particularly consultant companies, and that just drives up the price. So there is an incredible issue with supply and demand of knowledgeable people. The second point about the electronic health record, again, the importance of it is that between the ambulatory side and inpatient side, it should be seamless. Now, between many institutions, it wasn't actually mandated, the seamlessness of it. And actually, even in health facilities, if there are a number of different interfaces that one has to go through, the costs of maintaining those interfaces are very significant. But at the end of the day, it boils down somewhat to the physician. And the physician, whoever is using the electronic health record, has to maintain the electronic health record. They have to ascertain that it's accurate, because the electronic health record is only as good as the information you put into it. If it's garbage in, it's garbage out, and it doesn't mean anything. And lastly, I would say our experience, and we think the particular electronic health record that we purchased is an excellent electronic health record, but it's not easy to get physicians accustomed to it and facile with it. Now, that may come over time, but it clearly slows down the number of patients seen. And actually, it has an adverse effect initially on the number of patients that get seen and presumably on their income.
Well, the transition is not going to be easy. No. But I really want to give the audience a chance to ask questions. I know maybe the lights can come up, and I think there are microphones in the aisles, I hope. And if you come up to a microphone to ask a question, I'm going to beg you again not to make a speech. Just line up at the mics. Make the questions short and pithy. And please just tell us who you are when you, do you see the mics? Are they there? There you go. Right over here.
It just seems like the easiest problem that you've talked about to really rectify is the fraud and the abuse. And that's all technology, that's all data-driven. All the Medicare stuff goes through computers. Everything goes through computers. Why is it so difficult to find the fraud? Whether it's a bunch of doctors in Florida with medical devices putting their stuff in, I mean, some kind of red flag has to appear in a computer, or it should be programmed that way to be able to catch that stuff.
That's part of the story that I think is a good one right now. First of all, let me explain. Fraud is not error. Error is very widespread. Fraud is not. It's confined to a small minority, but extremely toxic criminal element basically in the system. The Affordable Care Act is giving us a range of tools right now. There are three basic levels. First is enforcement. We have strike forces with DOJ and the FBI in 9 cities, soon to expand to many more. Their yield is about 10 to 1 in terms of return on investment. We're doing more pre-screening of providers to make sure that they haven't been involved in fraud in advance. And most important, as the questioner implied, is what's called predictive analytics. That's what your credit card company is doing when you suddenly use it in Turkey and they call you and say, are you really in Turkey? There's a way to use the data we have, and all of that is expanding very fast. There's a deputy I have now in a whole new center on program integrity, and that activity is expanding fast. We're not going to tolerate this, and it's going to be stopped.
Okay, we'll go back and forth.
Hi, Peter Bach from Memorial Sloan Kettering. Thank you for a very interesting panel, and I think to echo Don's comment, I think everyone is right. I wanted to ask if we could hear a little bit, there's 2 components of spending, right? One is the number of services we provide, and many of the discussion points around how many MRIs we do, et cetera, is around that, the quantity of services. The other is the price of services. And the Secretary mentioned a little bit about pricing transparency, but if you look at these international comparisons, and Dr. Berwick made the point that we spend 2x any other country, it's actually the case that we spend the unit prices of most of the things we buy in healthcare, be it drugs or doctors' salaries or even the cost of a hospital bed day, actually exceed spending in most of these other countries. And it almost explains the entire problem, if you will. That doesn't mean we don't do more things, but I'd like to hear a little bit about prices. And on the hospital side, we actually have fewer bed days in most Western European countries. It just costs about 2.5 what it costs to hospitalize a patient in Europe.
Who wants to take on?
I'll say something quickly. I know Paul's the one who should talk about this. He's been very eloquent. I think there are bad pricing anomalies. We're working very hard on surveillance and comparison. Transparency helps, and there's much more transparency now, and there will be far more on the price of premiums, health plans, and sums products and services. The most interesting event this year in that realm is the results of the durable medical equipment bidding scheme. We have in 9 metropolitan statistical areas on 9 products. We simply went to bidding for supplies and services, a 32% decline in prices, almost 0 complaints. The complaints have been nearly 0 from suppliers and patients. Extrapolated to our Medicare as a whole, that would be $28 billion over the next 10 years, of which $17 billion goes to the Medicare Trust Fund, $11 billion gets returned to beneficiaries and lower premiums. It's a rip-roaring success, and we're now trying to expand it to 90 metropolitan statistical areas. And that kind of transparency and let the market work on price, I think, is an important step. Paul, I'm sure you have something to say.
You know, again, it's astounding to me how much we don't know and don't understand about how the whole price mechanisms work. So let me make an assertion, maybe it'll get somebody's blood going. You know, at the end of the day, I believe insurance companies are a pass-through agent for the providers. And so if you want to know where the force comes from for higher prices, it comes from the providers. The insurance companies are just passing it along. It's very hard to find an insurance company that makes significantly more than the cost of the capital they use to run their business. Yeah. You know, it's in American businesses, and they're categorized, health insurance is the 35th highest earner as an industry in the United States. So hopefully, if somebody would like to challenge that, be delighted to have that. The costs are coming from the providers. And it is true that technology is adding to cost. Electronic medical records are adding to cost. But underneath it is this opportunity for $1 trillion worth of savings by doing things that are basically industrial engineering ideas that could make an enormous difference. If you think about it, if we had a rollback of $1 trillion a year in health and medical care, we have a lot of other needs in this country that we could do something about, including reducing our unfunded liabilities and our national debt, which keeps rolling up like topsy. So there's no doubt about the need. The question is, how do we get energy? And I believe this energy has to happen at the local level. You know, Ken said something about, I do not believe the government can do this. I'm one who doesn't believe that the idea that every problem can be solved in Washington with financial incentives or financial disincentives or regulation is bullshit. I hope that's really clear. Right? The way for us to actually get this $1 trillion is on the ground in care providers organizing themselves in a way that they get better every day at what they do with the ideas of continuous learning, continuous improvement, which Bob told us that's what you're doing at NYU Langone.
Yeah, but Paul, I want to be careful when we talk about providers. Providers also include pharmaceutical companies.
Of course.
Okay, now, in the spirit of full disclosure, I have a significant investment in a major pharmaceutical company. And let me ask you this question. I can remember as a little boy growing up on the North Shore of Long Island, there were summers we couldn't swim in Long Island Sound because of a polio epidemic. Polio doesn't exist anymore. There's a place out here on the Cross Island Parkway called Creedmoor. It's empty. These were all state-run institutions. The maintenance cost of keeping a patient with severe depression or severe schizophrenia or whatever, I happen to think the most effective industry from the standpoint of cost to society has been the pharmaceutical industry. We take for granted now that we can get a pill and whatever hurts us is going to go away, and for the most part, that is correct. But I'm sorry, Paul, it's easy to say that providers have the incentive, but I'm a little bit worried that in this process of talking about what's too much money, we don't take into account the impact on our lives, not only in terms of length of life, but more importantly in terms of quality of life. And as I said, I'm an unabashed capitalist. I'm a proud capitalist. And I think this system works. And with all due respect to the amount of money that's wasted in the drug industry on research.
Well, but the system doesn't work because we have too many older people, and we're not going to be able to afford.
So we should kill them when they're 50 years old?
On the contrary.
Don't do that to me. I mean,
On the contrary.
So I want to go back to background again. Last year, in 2010 actually, is this data report from the Department of Labor. There were 7.5 million people who delivered care, health medical care in hospitals and nursing homes. 1 million of those 7.5 million people had an injury at work that caused them to miss at least one day of work or be assigned to restricted work because they were hurting, okay? Let me tell you this, I have a fact base. It's possible for people to work in hospitals and never be hurt at work, but it will never happen until the leaders of the institution say, people who work here will never be hurt at work. And maybe you don't care about 1 million people. I care about 1 million people, because if we could solve that problem, they would learn the tools and techniques that are necessary to capture the $1 trillion.
Okay, we're going to go to the next question.
Hi, my name is Anna Goldman. I'm a fourth-year medical student at Mount Sinai, and I'd like to thank the panelists, and I'd like to address my question to Dr. Berwick. I am considering going into primary care. I've applied into residencies in internal medicine. Primary care has always seemed like what I should do because it lowers costs, it's good for society, it improves outcomes. But it's scary to go into that right now because I see a lot of primary care doctors who are unhappy. I'm not interested in a lot of money, but I just want a livable life, and to be a full-time primary care clinician is it's very difficult to have a livable life, and most doctors I meet discourage me from doing that. So I know there's been some reform that has been suggested and recently passed, but major reform to reduce the disparity between what specialists are paid and what primary care physicians are paid has not really been addressed. So. And I think you're in a very powerful position to affect that change.
Special pleading.
What was your name, please?
My name is Anna Goldman.
Pardon me?
Anna Goldman.
Anna?
Yeah.
Nice to meet you, Anna.
Nice to meet you.
You're talking to the son of a general practitioner, a primary care pediatrician, and the father of a second-year resident in primary care, so you had me at hello. First, don't get discouraged. It's a wonderful place to be in healthcare. It's where you get to see people grow and develop. You get to coordinate what happens to them over time and space. You become their friend and join their lives, and it's just the place to be. We need to strengthen that, I know, and there are some we're doing now in public policy to get there. There are reallocations of resources to primary care, new efforts of investment in primary care centers. I think we've only just begun. Every strong healthcare system in the world, one that is really durable, one that really holds the patient in their arms and the person in their arms, is founded on primary care, not just doctors, also nurses in primary care and others, and we will be there. We've got to be there. It's part of the solution, because if we're going to have coordinated, frugal, gentle, safe care over time and space with the kind of chronic illnesses we're talking about, it's going to be primary care, which will be the home base. We have investments in medical homes and health homes now. The accountable care organizations will work, Bob. They really will. And I think you're going to find a much better place to be. I practiced every day for my 20 years of practice was in primary care, and I loved it, so don't stop, okay?
Thank you.
My name is James Stolman. I'm also from Mount Sinai. I'm a general internist, and that brilliant young lady actually stole my question. So I think what we should do is, as a national policy, make sure that people like that do go into primary care so we can have wonderful doctors like that woman, and that has to be an imperative. Because we graduated 47 residents this year from Mount Sinai, and only one person went into general internal medicine, and these were brilliant people, and these are the best and brightest, and it's actually a total tragedy. So my other question would be, Dr. Grossman, I understand the expenses of an EMR. We use Epic at our institution, but we have a proven EMR which is cost-effective, has saved lives, and has improved quality, and is developed by the government, and the government can make money, and it's in the VA Medical Center. I'm just wondering, you know, I'm not a capitalist titan. Why doesn't we just give the VA electronic health record to everybody? Because the future is we're going to have everyone on EMR, we're going to have 18 different products, and we're still not going to have communication. We're still not going to have transitions of care. We're still not going to have coordination of care. We're just going to have a lot of for-profit EMR companies.
So obviously, the VA has an electronic health record, and you can comment on the quality of that record, of the electronic health record. But the VA is a separate institution, and I don't think that the government and the VA would want to share their electronic health record with private, not-for-profit hospitals. And indeed, I think you've identified an important problem, and that is the interchange of information across electronic health systems, which is absolutely crucial to the care of patients. And it would be nice to have a single electronic health record, and I would love it. And it would, as I said, we're spending a fortune of money to implement an electronic health record.
And would it be nice if that profit went to the U.S. government, which did such a great job of developing this?
The VA record is publicly available to anyone who wants to use it.
Right, but we can't implement that record at NYU. Because it's not compatible with what we're doing.
Aha. So maybe you should be compatible with what's available.
Well, you could, that's a possibility, but we think, in actual fact, as far as I knew, that you couldn't implement a VA health record.
Well, I'll tell you a similar story. In Western Pennsylvania, the University of Pittsburgh Medical Center spent $500 million with Cerner, who's a provider of a lot of these electronic medical record ideas, and it's not interoperable. So as long as I'm in Pittsburgh, I'm okay, but if I go out, it's not interoperable with Bob's system. Right? Does that make a lot of sense to you?
Right.
Me either.
So that's why you have these health information exchanges that you want to develop, so you can exchange information across systems.
Here's a patient's problem: privacy.
Right.
Huge. when you're all cross-pollinating
Right.
and you can go in and.
Right, so there are several issues with respect to privacy and HIPAA that have to be negotiated across systems and between physicians.
So let's say a word about HIPAA. Everybody know about HIPAA. If you go to a medical provider, they give you a 3-page form. You have to sign and initial it in 3 places, right? Everybody done that, right? Okay, do you know how much it costs this nation to have that piece of paper signed by you? By law, it has to be stored for 5 years. Cost this country $500 million for that piece of paper, which is in no way useful for protecting your privacy.
Right.
It's just a damn piece of paper. You want to talk about saving money? We could save $500 million a year
stunning.
if we stopped scribbling on these forms.
But Lesley?
Do you want to jump in?
Yeah, I think we'll look back on this conversation in 5 or maybe 10 years and just smile that we had it. We're really en route to the modernization of information systems in American healthcare. I think the privacy problem is solvable. We have to respect it enormously. But what I'm seeing in the Office of the National Coordinator, which is the federal office that was set up a few years ago to try to make the progress that everyone wants to see, is very strong attention to privacy. I think it's solvable. Well, we're in an adolescent phase, and I think interoperability and the idea that I could cross the country and my record would still be available will be with us over the next few years. I know it's very uncomfortable right now. It's uncomfortable. If you want to seek discomfort, visit, as I did, all the rural hospitals on the coast of Oregon, where I was a few weeks ago.
While the privacy issue may be a negative, the benefits of the system
They're phenomenal.
in terms of knowing your condition, knowing allergies, knowing what you can't have, knowing what you do need. I mean, look, everything in life has pluses and minuses. I agree, the privacy issue will be settled.
I'm spoiled. I only ever practiced with electronic medical record because where my pediatric practice was an HMO that had adopted, was one of the first in the country to adopt it. I never saw a patient without having the record available to me. Every lab test was available to me the minute it came out of the machine. Consultation was on my desk the minute the consultant entered it. And if you want to see privacy problems, visit a hospital and watch these medical records stacked up on shelves and lying all around. It's possible to solve it, and it's so much better to practice in and to be a patient in when the information is there.
Over here.
Yes, Bernie Rossoff. I'm an internist, a gastroenterologist, and certainly interested in quality. First of all, I want to thank the panel for what has been a very interesting hour and a half. And just want to make a comment about Don and thank him very much for leading the country in terms of better care, improving the health of the population and the community, and in addition, affordable care. It's been very helpful, something that we really need. Just some misconceptions from the panel that I'd like to just correct, and then a question for Don. Just to Mr. Langone to start with, if we look at the Commonwealth Fund, and why not the very best, we find out that this country is far from the very best, although we spend the most money. We find out that our infant mortality rate is probably the highest in the industrial country. We find out that we don't treat a chronic disease very well, and we find out that our coordination of health care is not particularly good. So there needs to be improvement. There's no question about that. In terms of, Dr. Grossman, in terms of MRIs, there's no question that we know technology is very helpful. I'm not sure it saves lives or extends life, but we know it's very helpful. But there are too many MRIs that are used. Low back pain is a good example. A variety of other areas that we know there's overuse of MRIs and CT scans. If we don't take a handle on that, we'll never improve care in this country, and we'll be spending too much money. I think there are a variety of other things that we can go into that would be an example of how there is room for improvement, and we have to change the culture so we understand that there's room for improvement. We, for example, even in OBGYN, we deliver...
We need a question.
I have a question.
We need a question,
I have a
please.
question.
Okay.
My question, I just want to ask Don. I know the importance of preventive care. How would you suggest that we align the interests of the clinicians with the public health system so that we improve the issue of preventive care?
First, I can't help acknowledging Bernie Rossoff, one of the great physician leaders in the country. His courage has energized many. He chairs the National Priorities Partnership, which is setting goals for the country, which we all ought to be listening to. an emphasis on prevention is crucial. There are two kinds of important prevention, just to be a wonk for a minute. One is secondary prevention. There, the savings are enormous when you keep someone with congestive heart failure well enough that they don't have to go in the hospital, or you rehabilitate someone with a stroke who then doesn't have to bounce back in the hospital. This question of primary prevention, which you were talking about, is very crucial, way underinvested in this country in that. In the Affordable Care Act, there is a prevention pool. CDC has given some resources to progress that, and we also now finally can pay in Medicare for preventive services that are any preventive services that is scored as effective by the U.S. Preventive Services Task Force. So there's more investment now, an annual wellness visit you can have with your doctor. We need to keep that ball rolling. I became a Medicare beneficiary last month, and so I've got a stake in this, but I intend to live long and healthy, and to do that, I've got to be able to spend the time addressing the kind of issues you were going on. I think we're en route, but still underinvested.
Hi, my name is Alex Schmelzer. I'm a healthcare analyst at a New York hedge fund. I hope the Occupy Wall Street people aren't here.
Any good ideas?
I have a chronic condition, and I was a patient at the Mayo Clinic this summer for 3 days, and was utterly and totally floored by how coordinated the treatment was, how effective and efficient, and I actually couldn't stop talking about it and still can't stop talking about it. Unfortunately, the care that I received in New York couldn't compare, and it was very fragmented. I had to be my own advocate in a time when it was difficult for me to even pretty much stand. So my question is, why can't we, export what they do at the Mayo Clinic to the rest of the country?
Great question. Paul, you want to go for that one?
You know, for me, that's my dilemma. I've been working at this for a long time in a lot of different places around the country. And I would say I and my group have succeeded in creating astounding results, but they don't travel. Even when they're written up in refereed medical journals, people don't adopt practices that have been demonstrated. You stop killing people. And for me, it's really a dilemma in a society where we're talking about an industry where the people are as highly educated and intelligent and understand science as well as any industry, and yet they don't seem to have passion for learning from each other. And you know, it was interesting when I first started talking about 0 infections were possible. Lots of docs said to me, well, where's your white coat? You know, you're not a doctor. How the hell can you assert that people don't have to get infections? And, you know, we've made real progress. Nobody argues with me anymore that 0 is possible because there are enough demonstration points around the country. But what you say is really a dilemma. And, you know, honestly, if you go to Mayo, they're fantastic. They will say they're operating at 70% of their theoretical potential, so they don't think they've landed. And that's a really important thing. They're working every day to get better and better and better.
Dr. Grossman, I think you're probably the best on the panel to respond to this.
Well, I think it's I agree that the good practices and the best practices should be implemented across institutions. And the key is to identify them and then be able to implement them. And part of, I think, some of the, but what the gentleman was talking about was not necessarily best practices, but coordination of care. Yeah. And I think that's a separate issue from the best practices.
It is.
And we have to be better across the country in coordinating care for patients. And patients deserve quarterbacks. They need teams of people who are focused on their particular needs. But going back to what Paul said, implementing best practices will move forward with the electronic health record.
2 quick comments. Mayo is special. We could take a whole other evening talking about it, the essence of teamwork there, and that you're part of a system. And it's not accidental that Mayo was in part designed by an industrial engineer, and so back in its history. So systems are extremely well crafted there, and it could and should spread that general concept. But it would take new training, new investments, and a sense of reward for that kind of teamwork. This isn't what your question's about, but it's related. I have been visiting, as I said, many places around the country. I was in Alaska last month and saw in Anchorage a facility that projects knowledge out to all the native villages in Alaska through electronic communication. I've seen the same with the ECHO project in New Mexico, where from the university they now can help primary care doctors anywhere in the state, anywhere in the world, take care of hepatitis C and cure it, which would otherwise be very, very difficult. We have a frontier here of projection of knowledge through telemedicine and electronic communication that I think we're only beginning to tap. It's very, very exciting. The leverage and the cost implications ought to be very, very exciting. Not that I would say that to a hedge fund manager, but
Hi, my name is Jonathan Weiner. I'm a second-year medical student at Mount Sinai. And so this talk sort of began with everyone going around giving their suggestions about sort of what different interventions or implementations you can you can put forward in order to improve the healthcare system. And sort of as a diligent medical student, I started taking notes and tried to, kind of writing down what each one of them actually, documenting each one was. And I quickly lost count. And I guess my question for the panel is sort of what are those, one or two sort of key interventions that, that either, me as a future physician or sort of as a society we can really rally around? Because as you've mentioned, sort of, healthcare is, an over $2 trillion, business in this country, and there's obviously, countless ways to go at the problem. So, what are sort of, I guess, interventions that, even the four of you can agree upon to sort of say, well, these are, one or two or three sort of areas that we can move forward with, and I would cite either something that has kind of percolated here in terms of possible acquired infections from central lines, or even something from Peter Orzek's article this summer about driving down the healthcare costs.
Okay.
So someday, Jonathan, you'll run the system or a part of it, and then you'll have a different opportunity as a leader. Let me give you one suggestion, given where you are. Here's my suggestion. It's all about teamwork. It's all about interdependency. You may have been trained to be a hero, but you're part of a system. So do this. Next time you go on the ward, go up to the nurse and ask her this question. What could I have done differently last week that would have made your work easier? Begin to experience yourself as interdependent with the people with whom you must be a teammate in order to work. That nurse may first think you've gone crazy, but then she may give you an answer, and the next thing that'll happen is she'll ask you the same question.
That's great. I'm looking at our watch here, and I think we're going to have time for just two more questions. So we'll go here.
Hi, I'm Jennifer Silver. I'm with the Greater New York Hospital Association. We help hospitals cut costs in implants. I was appalled to hear that you think the providers are the highest cost areas. I think it's the implants. I'm confused about how salespeople can actually be in the OR putting implants into patients. We all know this is true. Most of my friends don't believe it when I say it, but it is true, and I actually saw it once. So why isn't anybody talking about transparency on implant costs, and how can we fix that rather than consultants like myself helping hospitals do it one-off? They can't look at each other's prices. Wow. Help.
Dr. Grossman.
I'm sorry, I didn't hear the question.
Implant prices.
Why are implant prices so high?
And what
How do we do
Decrease.
something? I agreed about the trial lawyers and the malpractice. How do we get the implant
how do we
costs down?
decrease
And can I add an addendum? End-of-life implants.
Yeah,
When
so
people are really
those
old.
are all issues, and obviously you can't have 6 different vendors in a hospital system where you don't have the leverage and can't get volume discounts for implants. But let me just suggest one other thing, and I think this speaks to about our high cost, or some differences in high cost. And that is, with the Dartmouth Atlas, there was a notion that our costs are very significant with respect to other areas of the country. But I think, actually, there probably is a different perspective. And one thing that you should look at is the cost of salvaging a patient. And as Ken alluded to earlier, the cheapest way to do this is for the patient to die. And actually, there was a very good study from University of Michigan in 2009 where they noticed that in surgical patients, there were quintiles of morbidity, and the complications were actually similar in all the different institutions, approximately similar. But the difference in the morbidity related to the ability to understand that there was a complication and treat it successfully. Now, I would contend if you do that, that costs a significant amount of money. And probably those patients survive more than the 2-year period.
I want to address one thing. We have to ask ourselves, as a society, what are our values and what are our ethics going to be? I have a dear friend of mine. He's 93 years old. He was my dentist. When I go to the dentist now, he goes with me. And I happened to go last week to have my teeth cleaned, and he even came to just watch him clean my teeth. This man is as sharp as a tack. He is remarkably alert. He's 93. Now, if Sidney falls and breaks his hip, should we say he's 93 and we shouldn't give him a new hip?
Well, it's
That's for society to answer, if that's what we want. I want to go back to the young man, the second-year medical student. Let me tell you what Home Depot did that was the most remarkable thing of all. We made certain that the people who were respected as the most important people in the store, are you ready? Were the kids that worked in the lot. Why? Because they were the last person that the customer came in contact with, and that would most likely be the memory the customer would drive away with. Were they polite? Were they helpful? Malpractice, it's amazing how many great doctors that have superb bedside manners that look at the patient as a person, not as a patient. The only thing I tell the kids at graduation, I tell them the same thing every year. Just remember that the person on the other side of the desk is hurting or in pain or frightened at what their health condition is. Think of them as a human being, not as a patient. And it's amazing how much more efficient we'll be, because I think I've read that the greatest diagnostic tool is the patient to tell the doctor what they feel or what's wrong with them. Is that correct?
The patient tells you the diagnosis.
All right, so the more we can create an environment of communication between the doctor and the patient, I think the better off we're going to be. But these aren't medical things. These aren't management consulting type things. These are interaction with one human being and another. And I mean it when I say we let the world know that those kids in the lot, I'm happy to tell you one more thing about capitalism. We have 3,000 kids that came to work for us in a lot that are multimillionaires today. Honest to God, there were 17 and 18-year-old kids, and they've gone all the way. Isn't that a good? That's capitalism at its best.
Stunning. That's stunning. That's stunning. All right, the final question over here.
Oh, I have a comment.
Or is it over
question.
there? I'm confused. No, okay, final question.
Yeah, I'm a doctor. I started off in general surgery. I graduated from SUNY downstate in the 1980s. I started off in general surgery, did that for a while, and then I did another residency in preventive medicine and public health, where the core course was actually your book, but I placed out of the course, and because of that, I got to take classes at Columbia Law School in health and mental health law, and I learned very well, and also from my experiences in surgery, why we have lawyers involved in the healthcare system, why we have so many lawsuits, because they keep the doctors honest. I saw a lot of errors that occurred when I was a general surgery residency, and some of them, the patients were very, very sick, and it was inevitable. But I'll give you one example, and I'm not going to say who it was or what hospital it was. A 6-year-old boy came in with appendicitis at 9 a.m., and the attending surgeon happened to be the vice chair of surgery at that hospital, and he didn't return, and we can't operate without an attending. So as residents, he never called us back until about 11 o'clock that night, and we took the little boy to the operating room. He had perforated his appendix. He lived, but he had to close by secondary intention. He was in the hospital for 2 weeks, and another case was a woman who had a colonoscopy. Okay, all right, anyway, and they perfed her colon, and she complained for pain for many, many days. She died. So what I'm trying to say is we see a lot of errors that are because people don't answer their beepers, because they don't care, and lawyers keep these doctors honest. And it's unfortunate that that's the way it is, but it is the way it is. And the third thing...
You're speaking for continuing the malpractice situation the way it is?
Yeah, it is the way it is because...
But you think it should continue?
Well, it keeps a lot of doctors honest, and it's a situation...
Who wants to take that one? All right. Who thinks we should continue the malpractice setup the way it is? Nobody. You get that one solved. Yeah. Dr. Berwick, we have run out of questions, and the evening is coming to a close. No, sorry. Time. I want to give Dr. Berwick, though, the final word, to sum up what we have learned tonight and where you see the problem of healthcare costs. Give us one avenue where you see we should go, the main one.
That's hard.
That's big. That's a biggie.
We must not go back on the commitment to have healthcare be covered for everyone in this country. That would be, it's not the country I want to be in. The only way we can sustain that in a system that I would be proud to be a doctor or comfortably a patient is if we understand what improvement of care can do. And until we have leadership, the public, the policymakers, the professions united in an intention to change the way we give care so that it is continually better, safer so people aren't getting hurt, coordinated so that the ball's not getting dropped, eliminating the kind of waste Paul's talking about. And if we think we can squeeze the existing system into performance, we are wrong. We need a new way to give care. And it's going to be done together or it won't be done at all. And that's my plea. Please believe in the promise of improvement and understand all improvement is change. I don't know, Lesley, if that's enough of an answer, but it's what we need.
Well, I would like to make a final comment about how impressed I am with this distinguished panel, not because they're all so smart and because they've educated us tonight, but because they care so much. Each one of them is really committed, I believe, to make the system better, and I think we're all behind that idea of squeezing the costs out and keeping patients safe at the same time. And if you keep, this is what I learned tonight, if you keep patients safe and improve medical care, you can also lower the cost. So, lesson learned. And I salute you all, and thank you.
Thank you.